Minu. Let's come to ones that almost all of us will meet in our day-to-day practice: a traumatic subluxation or intraoperative subluxation. These are the, as Dr. Minu said, that if you are not experienced, you can refer it to somebody who is doing it regularly instead of adding one more failure to your list. But then, yes, we discuss it. But what about these patients? Yes.
Thank you, Dr. Ajoy Paul. See, actually, I was a substitution for somebody else in this group, but still, I like this topics very much. And let me go into a lot of things have been told already. We'll be repeating many things, but then still, I will be talking about traumatic ones, usually which are not progressive. So basically, we should understand that there will be long-standing trauma, or it's a recent trauma, or whatever. Some lenses are very stable. So after many years, if you see, some lenses are very rock stable. If you touch on that, it will not move. But some lenses have diffuse sparse loss here and there, and if you touch them, they are very wobbly. So both these have to be dealt with very differently. So capsule bag stabilization is what is most important. So this is one case which came after many years of trauma. So many years. So on the table itself, on slit lamp itself, you should identify if, how many clock hours are there, and then if we should be ready with our armamentarium for whatever you saw here. But then on the table, when you put viscoelastic, you will see that it will be more than that. Could be more than that. So you please think that there may be more of subluxation waiting for you under the iris. So that is first thing I put is to put viscoat. No financial interest in viscoat, but then viscoat will, if you don't have vitreous, that is another condition. If you don't have vitreous in AC and having vitreous in AC, so this one does not have vitreous in AC. So if there is no vitreous in AC, this viscoat plugs that area. So that is first most crucial thing. And then you can put in either HPMC or sodium hyaluronate to facilitate your capsulorhexis. Because I am used to doing a capsulorhexis in HPMC. This subluxate one's rhexis is going to be more difficult. So if you're going in and putting in something like a sodium hyaluronate, and if the feel of your rhexis, moving your rhexis is different in that difficult situation, that will make things more difficult. So please stick to what you're used to in these kind of difficult situations. Again, I put in iris hooks. See, to me, capsular hooks are really cumbersome and big ones. And my idea is not to get an equatorial. In some situations I'll show you. But then my idea is not to get equatorial support by the long hook at the equator. So I am somebody who will put a CTR as early as possible if I see subluxation. See, I will show you cases where I wait till the end, but then you need to retain the bag till the end to put a CTR, So if you are scared that you will not have a bag till the end, then I will put a CTR in the beginning itself. So here goes iris retract hooks. So good, bad thing that this Alcon people have withdrawn these hooks. They are not available now. But then Aurolab is making similar ones, thinner ones. All the others are very big and clumsy and thick. But then this goes, I use one for 2 clock hours. So 2 clock hours of subluxation, use one hook. And then comes the capsular tension ring after a hydrodissection. So hydrodissection is very important, very gentle hydrodissection and segmental hydrodissection, so that you will get not a very forceful hydrodissection like you do in a regular one. And remember, the chamber is very full. So we should not be shallowing or deepening too much. So if the chamber is very full, your hydrodissection again has to be gentle with limited amount of fluid going inside. And the capsular tension ring, my way of putting a capsular tension ring is through the paracentesis always. So sometimes if you have the subluxation totally opposite to your main incision, then I can go through the main incision. But the problem with main incision is that you have to cover some distance into the cornea and then tilt the CTR down. So that is difficult actually. If it is a small paracentesis, you can go directly and the plane will be almost similar to the plane of your rhexis, and you don't have to bend the CTR too much. Some of the companies' CTRs are quite rigid, some are quite malleable. Please buy few and see, which are, I don't want to mention names, but then some are quite malleable and some are very stiff actually. You feel that you will break the bag with this. But all the ones which you see abroad are so malleable that you can even bend it like this, fish hook technique. What is that? Whatever. So this goes into the bag first itself. Now I have this equatorial support. Now comes the question of slow motion phaco. See, slow motion phaco does not imply lower power. So power is what is required for the kind of cataract which you have. It may be soft, it may be hard. So you have to have according to the size of your nucleus. But the aspiration flow rate and the vacuum. Here it is little high because I don't go to, because I didn't expect much of a problem in this kind of a very solid, rock solid lens, which is not much of a phagodonosis. But then aspiration flow rate is something which will bring in whatever is away from you. So if you have it low, it will aspirate only near your tip. That is the most crucial part which you have to keep, because if it aspirates more all the viscose from the area of subluxation, next thing you will get is vitreous out. So, and vacuum also not to get surge, not to get too much of surge. So here my technique will be regular. But initially I would do a trench, go into the center, chop once. Initial rotation will be little difficult than regular cases, because you will not have the support of the whole bag. See, the whole bag supported fully with zonules will not give you any, will not move, only the nucleus will move, but the lens also will move if you try to rotate. So gently rotate and slowly rotate. I will not use carefully, because everything has to be done carefully, but it has to be gentle and slow, and may initiate the movement slowly so that it will happen after some time, not in one big stroke. Once that is done, it is almost regular. But replace viscoelastic as and when required, and so don't let this area where the subluxation. Now most crucial part comes. Before taking out the irrigation, I'll fill up the bag again and the anterior chamber again, then take out irrigation. That is most crucial, because I don't want to shallow the chamber. First thing you will get vitreous out is, then it is a mess once you get a vitreous out. So till you have the advantage of not having vitreous out, please maintain the vitreous behind. This is how you maintain, by putting in viscoat or even sodium hyaluronate. But sodium hyaluronate, if you put and go in for this aspiration, it will come out in bulk very fast. But viscoat will remain there, it will take some time, but then it will remain and plug that area better. And now aspirating this is little difficult. As you know, the CTR would have definitely captured this. Remember where your eyelets were. Where the eyelets are there, and when they are over, if they are overlapping also, but from there you can tease out the initial part of the cortex. And once that is done, you can tangentially pull the rest of the cortex. Don't go here and there, one clock hour, then 6 clock hours away. Like that, if you pull, you will not get. I'll show you in videos later that it is very difficult to sometimes get out cortex. Once that is done, again, without taking the irrigation out, fill up the bag. And then put in the IOL of choice. If it is a minimal one, I will put a single piece lens. Single piece lens is also okay, but if you don't want to have a CTR and you want to support it with the 3-piece lens, I would put a 3-piece lens also into the capsular bag. So then capsular hooks and cortex aspiration. See, this case, you don't see much of an area of zonular dialysis, but then when you touch it for a rhexis, you will see wherever you move, the lens is also moving. So that means it is, now I put in more visco, and now this area shows up here. There is a subluxation more that side. And this is again another indicator. When you try to hold the capsule, it will show wrinkles, it will show folds. So that is an area where there are no zonules. So here there are no wrinkles here. That means you don't have zonular loss there. So this one going in. It supports the periphery. That is good actually. And you are not actually trying to pull it up. You are supposed to just have the tip at the equator. See now, this kind of a sheet of cortex is not at all coming. You have to be very patient and very slow. You know, keep on tagging like this. You know, it doesn't come at all sometimes. So the point here is that there is a big sheet of cortex from one end to the other. See, notice here, big sheet of cortex. So if this can be dislodged and separated, then you can bring it out in pieces. And then also you can have better visualization by putting iris hooks and retracting it much better. And now if you notice, they are little more free, and it can. My time is out, huh? Really? 8 minutes over. Okay, fine. And then the lens goes into the capsular bag. So intraoperative subluxation, this is one stage when one of my trainees called me. He said there was some movement, but I finished. But there is some movement of the bag or something, and the pupil was very small. Then I put in iris retractor hooks, and then it was all full of visco. And then I tried to put in the Simcoe and aspirate. See the bag coming out. See, this was stretched with visco and it was hiding under the iris, and I put some hooks and retracted the iris and saw almost 180-degree dialysis. So when the iris is covering up, you may not realize the whole thing even till the end of the case. So here, this is a whole big 180-degree subluxation where I had to support again with the CTR, and because already the suturing, the CON ring and everything has been shown, I don't want to talk on that again. But late implantation of a CTR, if the nucleus is so hard and it is grade 4 or 5, And if you think that implanting a CTR with the whole lens inside, this is a very hard nucleus and the whole lens is moving, wobbly. So if you put a CTR inside and if you think it will compromise the zonules further by putting in a capsular tension ring, then I would not. See, putting in these hooks, you can get away with this in most of the cases, but sometimes you'll see that this is just hanging loose. Because if your irrigation is very high up and you put in fluid there and suddenly the chamber deepens, these hooks just come off. So then you won't be able to look at it and you'll be looking at the nucleus, but then this will be off. So please do not have a very high bottle height when you go in with your phaco probe, when you have iris retractor hooks are putting. The whole case was done with the hooks retracting it, and once this is done, the CTR goes into the bag and you can stabilize the bag like this. Sutured, I'm not going into it because it has already been shown, and thank you very much.
Thank you.
Thank
Dr.
you,
Minu. I think
Dr.
anybody
Minu.
has any question, he showed those traumatic ones that you meet everyday practice, and especially on the table suddenly you see, your resident must have seen that case, and then you are taking suddenly you find that lens in how to go about it, and very useful tips. And I think you didn't cover that. When you get it, suddenly you have caught some part of it. I think that's again the CTRs that would. Minu, please continue sitting there in the panel, I think.
Thank you, Dr. Minu. Just one little question, basic question. In these cases, would you like to do it topical or you will go for peribulbar?
Unless I see something intraoperative, all subluxations are under block. Sometimes I don't see all the cases and they come up on the table and you see that they
in
are
a planned way, you are going for peribulbar.
I will go for peribulbar.
Yes.
Every case.
What pressure you give?
What?
Do you
Pressure.
get
What
picky?
pressure? It's the anesthetist who blocks, but then every case it is written very mild, gentle massage. It is written very bold letters. We have had anesthetists push down lenses and on the table it's hanging
On the
down like
table
this. We have
it's
seen.
this
So it will be just a continuous pressure. The 30 seconds pressure, leave it. 30 seconds continuous pressure and very gentle pressure for a long time, so that it takes time and gets.
And I was surprised to see in the first two videos that your bottle height is above 100.
Bottle
Do
height
you
is,
always go for that?
because see, the thing is, when you have these kind of low settings, very low settings, this will be okay. But if you come down, I am more worried about surge than having a higher bottle height.
But what is
Surge
your
is-
message? Should it be above 100 or it should be
low,
below?
but you should not get surge.
Yes,
If I get
okay.
surge at 90, I will bring it up to 100.
Thank you so much.